So I see that we already have Dr. Kasim and Dr. Untrak here to be the panelists for our meeting today. And so it's here in Brazil, it's 2:01. I think it's 12 p.m. there in Miami, right?
Correct.
Yeah, so feel free to start whenever you want, and I'll help you moderate the session. I don't know if you have any stops in the oh, you do have? Okay.
Yeah.
So
yeah.
it's easier to make sure everyone can comment on the case. Okay, feel free to start whenever you're ready.
Yeah, perfect. I'm Gareth Gilna. I'm a chief resident here at University of Miami and Jackson Hospital. And I'm going to be presenting a case that we had about a month back, blunt trauma. And then kind of as Dr. I'm going to butcher it, but Menegozo, excuse me, said it'll be kind of a, at decision points, we'll stop and we'll discuss how people would manage these things and what the next step would be. Is my understanding of kind of the format for this. So we'll go through and there's a number of decision points and we want to hear from everybody here what their thought process is and what they'd do. Let's see. So this was a 19-year-old male who he actually went through our emergency room before coming to our trauma bay, who was in a scooter crash and hit his, and this is like the motorized scooters that have like the handlebars, not a moped or a motorcycle, but just a scooter, fell, hit the handlebars, and came into us. His airway was patent. He had bilateral breath sounds, but he looked sick. His heart rate was 120. He was hypotensive. He was confused, and he was peritonitic, and his FAST was positive. While we were in the trauma bay, we gave him 2 units of whole blood. And then I guess this is our first stopping point. I think it'll be pretty brief, but.
Yeah, no worries. Dr. Untrak, do you want to start with one?
Certainly. Well, he's got all the criteria for being taken directly to the operating room. So you're transfusing him, and while you're transfusing, or go to the OR, do a laparotomy. I assume it was positive. Yeah, you said all 4 quadrants and negative EFAST, so negative in the chest. So yeah, he needs a laparotomy. So you worry about bucket handle injuries, for this kind of a thing, but as the title of your talk says, you might find something else, but needs to go to the OR.
That's great. Dr. Kasim, do you agree? Would you do anything different? Would you take this patient to the CT scan?
What were his vital signs? I didn't get that.
He was hypotensive and tachycardic.
Okay. And
he did respond to the blood transfusion, but was still hypotensive.
Did he respond?
He did. I mean, we took him to the operating room pretty quickly, but he was transiently responsive to the blood transfusion.
Well, it is not a good idea to go to the CT scanner when a patient is hypotensive, in spite of getting some fluid in the form of blood. So I would not take him to the CT scanner. And this is a kind of injury that you become a little perplexed, because when there is a penetrating injury, there is a trajectory, then you know what is happening. You have some rough idea where you're going to be looking for. But in a blunt injury like this, all bets are off. So you are in a blind corner, and it's not a good idea for a surgeon to be blind. So the safest thing would be what Dr. Untrak says. I would take him to the operating room as well.
I think another talking point that we had was, would you get a chest x-ray before you went to the operating room?
Yeah, nice one.
If the time allows, and if all the other stars line up in your favor, yes, I would. But otherwise, I think you'll have to rely on ultrasonography. Make sure that he doesn't have any latent pneumothorax, which will complicate your intubation and perhaps tension pneumothorax, etc.
Yeah, I think the process at our hospital, we booked him for the operating room, and the process is not immediate. You know, they have to open up the instruments and everything. So we got a chest X-ray, and that's kind of our standard practice at Jackson. It seems like where we'll get the chest X-ray before we go.
Did you do that in the trauma bay?
Yes,
Well, then it's okay.
right.
That's great. Dr. Gustavo Fraga, you are on the meeting as well.
Hi, Carlos. Can you hear me?
Yeah, we can.
Hello, good afternoon, everybody. I think I agree. If the patient is still unstable, hypotensive, I think should go direct to the OR. But if after blood transfusion, if the patient recover, if have time to have a CT, sometimes CT is very important because maybe this patient has a complex hepatic trauma, something that you can access angioembolization. Depends how the patient is after the transfusion. If the patient is still hypotensive, I agree go to the OR. Thank you.
All right. So, Dr. Garrett, I think most of the participants would do would go to the OR directly. So, what did you guys do?
Yeah, I think I already spoiled it, but we went directly to the OR. We intubated in the OR, and then did a exploratory laparotomy, packed all four quadrants, found a decent liver laceration right along the falciform ligament. And then the most immediate next injury that we saw was a large zone 1 hematoma that was above the transverse colon. So this is our next kind of stopping point for what you would do next.
That's great. Dr. Untracht, any thoughts?
Yeah, I must say sounds like a great case to use on the part 2, the certifying board exam, the orals, because it's got it just everything very textbook, very straightforward. Zone 1 hematoma needs to be explored. So it's you said zone 1 at the level of the transverse colon, right? So you need to look for pancreatic injuries, aortic injuries, and he went over the handlebars. So I suppose also, this is one of those injuries, depending on how fast he was going, where you worry about chance fractures. But but this hematoma in zone 1 needs to be explored. So divide separate the omentum from the transverse colon, open the lesser sac, examine the pancreas, and you might need to do other maneuvers, the Cattell or Maddox maneuver to get a good exploration of the aorta and the great vessels and the vena cava. But you can't leave without exploring. And as Dr. Fraga said, that sometimes if the patient is stable, good to go to, if he responds and remains stable, good to go to CT. And in Dr. Fraga's hands, he can probably do everything without taking a scalpel to the patient, sometime in some of these cases. But that would show you any severe injury to the pancreas or the retroperitoneum, some of which, if it's a vascular injury, you might be able to deal with through intravascular means.
That's great. Dr. Hochman, so we don't have the CT scan for this patient. Do you agree with Dr. Untracht's opinion about how to explore this abdomen?
Muted.
Sorry,
Yeah.
can you hear me?
Yeah, we can.
Yeah, no, I have nothing to add at this time. Thank you.
Excellent. Dr. Kassim, do you have any other thoughts?
Yes, I do. So when you see a patient with a zone 1, the first thing you need to do is you call for assistance. You need a third hand. 2 hands are not going to be enough. Make sure you get anybody, even a medical student, because you don't know what you're going to be finding, and you may have to get control of uh, the the thoracic aorta as it emerges from the hiatus, and you may have to put a pedal there. So make sure that you get some assistance. Then I would agree with Dr. Ultrach that I would do a Catalan brush maneuver, open it up and have a good look and see what's going on. Because this is going to be a complex injury. It won't be just one injury. It may have 2 or 3 components to that. You can have injury to the duodenum, pancreas, or blood vessels in that area. Even one of the 3 portal triads could be injured. So those are the things that I would be cognizant of and make sure that I can tackle that with a lot of help and clear visualization. Thank you.
Dr. Untracht, considering this is a zone 1 bleeding, a hematoma, would you consider doing any type of vascular control before exploring the hematoma, before doing the Cattell brush maneuver?
Well, yeah, it's like just like Dr. Qasim said, that there's the potential for injury to the aorta or one of the branches. So you need to be prepared, and it depends on the condition of the patient. So in 19-year-old, so I assume he's thin. Is that the case, Dr. Gilna? Yeah. And probably would be very easy to get control of the hiatus, as Dr. Dr. Qasim said. And there's that option. The other option is if you adequately prep, so including the thighs and down to the knees and up to the sternum, you can access one of the femoral arteries and put a guide wire, and so if need be, you can use the Reboa to get control if you're short of space. And as Dr. Qasim says, you may need all your hands to do surgical things, and you may not have space. That might be an option. You can do that in case, have it ready in the OR, but certainly you need to be prepared for a major vessel injury.
That's great. So, Dr. Gareth, I think you can move on.
Yeah, that's a lot of the talking points that we had the morning after. So we ended up getting supraceliac control. Dr. Mezoso, who was the attending in the case, and I were lucky enough to have 2 IVC injuries within a couple weeks of each other. And for this one, the patient was stable, skinny, and so we had some time to get supraceliac control before we did our right medial visceral rotation and complete Coker maneuver before exploring the hematoma. Versus we had another one that was a gunshot wound to the IVC, and the patient was very sick and didn't have time, and it was a very large patient and didn't have the possibility to do a supraceliac control. But for this one, we did it. We ended up not having to do it or having to use it or clamp the aorta. But then we found a 3 to 4 centimeter longitudinal laceration on the IVC. And then again, this was, we know everybody's going to, try to repair it or at least attempt to do it, but it was a discussion point on kind of what is your technique for getting control of the IVC, what tools you use or what clamps you use, and then how you repair it and your approach.
Yeah, that's a great point. Can you just describe the injury again with more details so we can spread the word here with the panelists?
Yeah, sure. So it was anterior midline, just pretty much straight up 3 to 4 centimeter long laceration of the IVC.
Okay, and it's clearly below the renal vein, right?
This one was, yeah.
Okay, Dr. Untracht, any thoughts?
Yeah, so and it's just anterior, so that simplifies things. If it's a penetrating injury, usually it's through and through, so you need to sew the back wall from the inside. And depending on the condition of the patient, the other injuries, it sounds like in this case, you don't need to do damage control. But if you did, one option is take a large chest tube, insert it as a stent, and then some vessel loops doubly wrapped above and below to get control, and then you can allow flow to continue as you sew it closed. But here, probably you can just use a couple of sponge sticks above and below for compression, and then just sew it closed quickly, faster than you would do those other things. And I think that's probably what you did here, since it was accessible and you already did the Cattell maneuver, so you would have had excellent exposure, and you could have dealt with it immediately. And also that raised the issue: how did this happen? Longitudinal, clean cut, so obviously it's blunt. So, you'd have to, and if it was a clean incision rather than just frayed edges, but I think you have to worry about the viability of the edge that you're sewing through. So I don't know if you had to debride any non-viable parts, but it's a little intriguing how this happened. But still, I'm sure it was simple to deal with.
Yeah, the IVC was not necessarily a clean cut per se. It was pretty beat up, and we didn't discuss kind of resecting the edges of the IVC or anything like that. But it was not like completely normal IVC that just had a laceration on it. There was a lot of hematoma and beat up tissue around the area.
So I think that's the one little monkey wrench in this case. So, and that's why they say prep from the clavicle to the knees, have one leg available in case you need vein, because the only difference would be, instead of just quickly sewing it up, to take a piece of the upper saphenous vein to use as a patch. You might need to do that, and it may take a little longer, but it'd be very important in this case. You don't want it to dehiss, post-operatively, and have them get hypotensive on the floor after he's out of the trauma ICU. But that's the one little glitch in the judgment, in the management that consider.
Yeah. Dr. Kassim, any thoughts on that?
I think I will follow the KISS principle. Keep it simple, stupid. And in a situation like this, you want to do the minimum to get the maximum benefit. And what I like from Dr. Untracht's dissertation is I would immediately go for the double sponge technique that he described. Get two sponge sticks, one above, one below, and you're looking, it is an anterior tear, so you don't have to worry about the back wall. And I just sew it up very quickly and get out. Don't try to do any fancy maneuvers in there, because then you will cause more tear and more problems. Always remember the KISS principle. That precedes anything else like shunting, grafting, and patching, and all that sort of thing. The reason why this happens is a deceleration injury. The vena cava was probably full of blood, and in the injury it tears. And similar to any other hollow viscous which is fluid in it, in the deceleration injury it tears. That's what I would do. I would apply the KISS principle. Thank you.
Perfect. Dr. Fraga, anything to add? And also, what kind of suture do you use in these cases of vena cava?
I always respect retroperitoneal hematoma in zone 1, because always is a difficult situation. But at this time, was identified a cava vein injury in anterior infrarenal cava vein to have the decision. If you have the proximal and distal control, you can do the suture of the cava vein. Usually you use polypropylene 3040 to make the suture. But I think the patient was better at this moment, was stable, because if the patient is still on shock, not recovered after the massive transfusion protocol, some situation is necessary to ligate the cava vein. Obviously, it's better suturing. So I have a question: how was the patient at this moment of the surgery? How many blood has the patient received until this moment?
Yeah, it was we had initially a difficult time getting control of the IVC. MTP had been started. I think he ended up getting around 25 products throughout the operation. There was a gonadal vein that was also where lacerated at the area, which kind of made our getting the hemorrhage control a little harder until we recognized that. But yeah, we eventually relatively quickly got it, but initially there was some serious hemorrhage.
That's great. Dr. Gareth, there's a question on the chat from Dr. Almeida. She's asking, did you try to look for or take out any thrombus inside the vein before the suture?
We did not, and we didn't discuss that. But
the one thing I'll mention is that this was still audible bleeding, so it was, if there were thrombi, they were gonna flush themselves out.
Jeez. Yeah, it makes sense. That's great. Dr. Hoffman, do you have any tips for doing these vascular sutures in terms of what type of suture do you use? What kind of forceps? What cautions should one take while doing this suture, not to like tear more of the IVC or any other vascular structures?
I try to keep it. I'm as Dr. Kasim said, this is the KISS principle. Once a medical student told me in very dismissive way that probably a trauma surgeon invented the KISS principle, which I reply, if that's the case, I will be very proud, because I think it's an excellent principle in trauma surgery. So I had the chance during my career to deal with quite a few IVC injuries, blunt and penetrating. I never ligated the IVC, although I totally agree with Dr. Fraga that if the patient is hemodynamically unstable, ligation is the option. You ligate and you get out. I remember participating in a case, it wasn't my case, I was a junior attending when the IVC was ligated, and the outcome was really, really bad with significant peripheral lower extremity edema and complications from the ligation. So maybe that scarred me, and I always find a way to repair. The way I do it is even more simple. I don't use a clamp, I use the fingers. In cases like this, I put 2 fingers over the IVC, one proximal and one distally, and put pressure, and usually that's enough to control. The problem is that Dr. Almeida, who was in the Dr. Epstein, they mentioned there, sometimes you have lumbar veins that are bleeding behind your compression. And that really complicates all the repair. Sometimes you need to make the hole bigger to be able to ligate the veins, or sometimes you can put a Satinsky over the edges and suture on top of the Satinsky and allow the flow from the IVC. It all depends on the injury. These type of longitudinal injury are surprisingly common. No, I would not say very common, but they are common. And so using 2 fingers to control, and after that, if there is no back bleeding, do a quick suture with 5-4 Prolin usually is that's the trick. I prefer to do that rather than ligating. So far, I have been very, that served me well. I'm pretty sure that tonight when I am on call, I will have to ligate one because I just burned myself by saying this. Thank you.
That's great. Thank you very much. Dr. Gareth, you can move on.
Yeah, seems like we did pretty similar to what people were referring to. We tried, before we explored the hematoma, we had 2 sponges on sticks ready, had 2 suction canister or 2 suction ready. It actually ended up kind of similar to what Dr. Hodman was saying. Our the sponges on the stick were not as effective, and we just ended up having to do manual pressure on the IVC. And I think part of that was contributed from that gonadal vein that we talked about, that was also avulsed. We used Alice clamps, which is what most of our attendings here at our hospital use for IVC control, and then primarily repaired it with the 3-O-proline. And then here on the right, you can see our repair. It was not stenosed more than 50%, and it was hemostatic after the repair, and we felt pretty comfortable that our repair was, that we were happy and we didn't have to ligate the IVC. But while we were finishing our repair, we noticed, oh, I guess it's a video. I mean, doesn't really add much, but while we were doing this, we noted that there was bile draining into the field of the IVC. And we obviously were going to explore that area anyway, but we found that the common bile duct had avulsed off of the duodenum right at the ampulla. And that's you can see the DeBakey clamp holding the duodenum here. I don't know if you can see my cursor. This is the portal vein, the pancreas, our IVC repair. Yeah, so our duodenum had just right at the ampulla had avulsed. So again, this is kind of the next decision point.
That's great. Let's start with Dr. Kassim this time.
Like I said earlier on, there will be more than one injury in zone 1 injury, zone 1 hematoma. And I'm glad you found the second injury, maybe even a third injury, probably, I don't know. So you have avulsed biliary 3. I take it as a common bile duct. So now you need to look at the status of the patient. How long have you been in the operating room? How much blood you have used? What is the status? Should you go ahead and do heroic measures here, or should you revert to damage control? In my opinion, this patient is probably has gone through hell. He has received over 25 units of blood. Is that what you told us? I think you said something like that.
Yes, sir. It was, I believe it was 25 product.
25 units of blood.
Yeah.
And anybody who receives 25 units of blood, it is not a chicken feed. It's a lot of blood. And I think I would probably convert this into a damage control option now. Now that I have a torn common bile duct, is it completely torn, circumferentially torn? Or avulsed, completely avulsed?
Yes.
Yeah. So Gareth, can you go back to the picture so they can see it?
Okay.
Yeah.
If it is completely avulsed,
You can actually see it here in the picture of the IVC repair. Up here is
right,
where I mean, we didn't recognize it immediately at that time, but that's the common bile duct there too.
okay. Oh, there it is. I see that now.
Yeah, in that DeBakey.
Well, depending on the patient's status at this moment, I could put a chi tube and close that end and then come back some other day. Or if the patient is fine, not having any problem, and see if I can mobilize the duodenum and do a choledochoduodenostomy, which will be easier than doing a Roux-en-Y duodenostomy. And so it depends. I think I most likely will go for choledochoduodenostomy. Mobilize the duodenum and make a little slit in the duodenum and re-implant that common bile duct with a T-tube in place.
You would do that now,
And
Dr. Kasim, at this operation?
like I said, it depends on the patient's status. If the patient is very stable and I have time, I would at least think about it. But like I said, he has received 25 units of blood, and I think that would put him in a class class D, which is close to death. And I may just put a T-tube and get out and go back and do this some other day.
Yeah, that's great.
So I have two options. And I have to choose which one I'm going to go.
And
That's
Dr. Byers had a comment in the chat. I was wondering if she would be willing to chime in.
Kevin, can you?
Yes.
Okay, thanks. So Dr. Byers can tell us all what you're thinking in the chats. So Dr. Byers, are you able to open your mic?
Finally, I'm allowed to unmute. You had me muted, which is really rough for me. So in the IVC repair, how I usually do that is at first I use the two sponge sticks, put a bunch of Alice clamps till I get figure out what the full length is. That slows the bleeding down to a dull roar at least, and then put a big Satinsky clamp, and then sew it with a 4-0 or 5-0 up and back to make sure I overlap all my sutures. And usually that takes care of most of it. It's a great case, Jonathan. Lucky you. Now for the bile duct, what I would do in this case, I agree with a choledochoduodenostomy as an ultimate plan, but I think with the 25 units of blood, Dr. Kasim brings up a really good point, that I think I would ligate it as close to the end as possible with a fairly good sized protein that's easy to go back and find, and allow it to dilate up. And then go back and do a choledochoduodenostomy after your bile duct is dilated. That's personally what I would do.
That's great. Thanks. Dr. Untracht, any other thoughts?
Well, before Dr. Byers spoke, my thought was if it was completely avulsed, then there's no distal limb to put the T-tube, and then I would have placed a red rubber catheter, ligated the duct around the red rubber catheter, externalized it, and then there's the concern about, first of all, doing an immediate repair, and also doing the repair with an undilated duct, with a normal sized duct. And then after hearing Dr. Byers' opinion, I would, in the future, I would do what she said, to ligate the duct, dilate it, or maybe if I had put a red rubber catheter, clamp it to let the duct dilate, and then you can unclamp it. But still, you worry about doing a reconstruction with a normal sized duct. It's doable, but it's not ideal.
Yeah. Dr. Byers, you have your hand raised.
Yeah, the only thing I would say about the red rubber catheter, I mean, that was another consideration I had, but in further thinking about it, the reason I would do this instead with a ligation at the end is because any length that you have the red rubber in the duct may cause some inflammation of the duct. And this way, when you go back to sew it, you have a nice fresh duct and the longest duct possible that you have to suture to the duodenum.
That's great. Great comments. Dr. Gareth, I think you can move on.
Yeah, I think those are all mostly the discussions that we had during the case. Luckily, this happened at about like 5 p.m. ish, and so that's right when we do a handoff. So we are one of our more senior attendings that's a hepatobiliary surgeon that also works with the trauma department was there, and he was able to come by and put eyes on it as well. And his advice to us was similar to what Dr. Byers was saying, that we ended up not even putting, we discussed putting a T-tube in or some type of drain to externalize the biliary drainage, but the hepatobiliary surgeon just recommended just leaving drains and not even putting anything into the common bile duct, just to preserve as much length as you can have. And so that's what we ended up doing. So we just left a JP drain by it, did a temporary abdominal closure, and took him back to the ICU to correct coagulopathy and all of the normal damage control stuff.
Yeah, that's great. Dr. Gareth, let me interrupt you for a second. Dr. Byers and Dr. Hochman have their hand raised. Dr. Patricia Byers? Oh, I think just Dr. Hochman.
So a few things with this. One is the way that this common bile duct is there hanging a long segment. The perfusion of that segment is probably compromised. The common bile duct has usually small arteries running parallel to it, and there probably are balls with this too. So it's likely that the distal end that you have there is going to die. The other thing is, when I trained back in Argentina a century ago, I trained in a place where we were doing a lot of hepatobiliary surgery. And when you have a common bile injury, keep it simple. Ligate, and particularly in a case like this, ligate and get out. Don't try to do a repair at this time. This patient is too sick to do any repair. The third point is that there is another end to this. Where is the other end? So it has to be a hole somewhere in the duodenum, and I don't know where the other hole is, and it's going to leak all over the repair in the IVC. And this is the part that would be worried. I would probably ligate for the reason Dr. Byers mentioned before, just to dilate the duct because it will make the repair easier. It will also help me differentiate the area that will potentially necrose. And after that, do the repair even a few days later. I will let this dilate for a few days rather than repair immediately. But I will also avoid the contamination over the fresh repair in the IVC, which I will be very worried at this time that I can get infected. So I will do an extended Cocker maneuver. When I do a Cocker maneuver in trauma, I always go to the left side of the aorta. That's what I consider a complete Cocker maneuver for trauma. Try to find any hole, because it can be a hole in the pancreas, it can be a hole in the duodenum somewhere. And if it's a hole in the duodenum, I would try to primarily repair if possible. And after that, get out and live to fight another day, not today. That would be my approach for this. Thank you.
We had done a complete Coker maneuver, and we did find the area where it had avulsed off the duodenum and put some Lambert sutures over that area.
Yeah, great comments. Dr. Gareth?
Yeah, so again, kind of like everybody said, I mean, different techniques, but we left drains, did a temporary.
One more thing. I have a case recently, and I asked for a T-tube, and I was told in the hospital, we don't have more T-tubes anymore. We have T-tubes. And I got mad. I said, why we don't buy T-tubes? And they're not being made anymore. They stopped making them. Nobody uses T-tubes anymore. So
I'm glad you mentioned that, Dr. Hodgman, because I asked for a T-tube in preparation for maybe needing one. And I got looked at like I had 6 heads, and they told me that we absolutely don't have them and that they're not being made anymore as well. So I started adding pediatric feeding tubes and all sorts of other things just in case I needed something to put in there.
I'm surprised they didn't say, what's a T-tube?
Yeah,
They did. So the patient, we took him back to the, I guess we just did that. We left drains, we packed the liver because there was that laceration there. Took him back to the ICU, corrected coagulopathies, and then we took him back on postoperative day 2. And we've already heard people discussing this, but want to get more into the weeds of what type of repair would you do when it came time to do your repair.
All right. I think Dr. Kassim spoke a little bit about how to manage this. Dr. Untracht, do you want to add something?
Yeah, I mean, for if you have a long segment and the long segment of duct and the duodenum is nice and floppy and there's no tension on them, you could do a colodoco duodenostomy, and you just have to, use a very good technique as always. But the issue is that you're dealing with a normal size duct, so you can't to create that funnel as described classically. I mean, you can extend the incision up the anterior wall of the duct, staying away from the lateral sides where the blood vessels are, and then that would give you a little bit longer circumference of anastomosis. You could leave an intraluminal tube through it, like you sometimes do with small anastomoses exited through the duodenum. But I think you could probably just get away with doing a colodoco duodenostomy or a Roux-en-Y limb if the patient has recovered from his physiologic derangements. And if you can't bring the two duodenum together with the bile duct without tension, then it's safest just to do a Roux-en-Y limb. And then, if you're worried about devitalization of a bit of the end, it's not an issue, because you can just bring the limb up as high as you need to. You might have to take out the gallbladder in this case, depending on what you find, but otherwise it'd be fairly straightforward.
That's great. Dr. Hochman, do you want to talk about any other pros and cons about the colodoco duodenostomy and the Y and Roux limb?
You always try to keep it as simple as possible. That's the same. So if you can do a colodoco duodenostomy, that's great. I don't know how viable that distal end of the common bile duct is. They open like a fish mouth on the common bile duct helps if there is a big discrepancy. Traditionally, colodoco duodenostomies are being done for some obstruction of the papilla that cannot be relieved, and you need to have a diameter of 1.2 centimeters. This is very small. This is almost like you will do in a liver transplant. So if it doesn't reach this any tension, a Roux-en-Y will be a much better option. Most likely that not that I would do in this case, because I don't think that will reach. But if it reaches and it can be done, the KISS principle, keep it simple. If it reaches, do it.
That's great. Dr. Kassim, you just open your mic. Yeah, it's muted.
I recently heard the same thing happening in Portland, Oregon, that they were looking for a G-tube. They couldn't find one. So they used what is called an Inahara shunt. Dr. Inahara was a vascular surgeon at St. Vincent's Hospital in Portland, Oregon, and he has a shunt. And that shunt became was in the room, and they used it successfully. I thought that was pretty smart.
Interesting. Nice. I see that Dr. Meizoso just answered. We kept it even more simple. Dr. Jonathan, do you want to comment on that?
Yeah, so I think a lot of great points have been raised. One of them is the concern for devascularization of a decent portion of that common bile duct that was exposed and basically circumferentially dissected for us. So that was a concern. And because of that, we had to trim it back a decent amount. You'll see a picture that Dr. Gilna will show you shortly. And so we actually elected, again, my very senior partner, who was my program director when I was a resident, is the person I called, who many of you probably know, Danny Sleeman, who's been around here for a long time. And his elective practice is doing Whipples. And so he does this, all day long, several times a week. And he also takes a lot of trauma call. And so I asked him to help me with this. And his suggestion was just to do the same reconstruction that he does for his Whipple procedures, which is actually just a loop hepatocogeginostomy, which is what we ended up doing. And that was very simple. A lot of times for his Whipples, he'll also do a brawn enteroenterostomy, which we ended up not doing for this. But we kept it very simple because it was there. The loop of jejunum very easily came, right up to the level where we had trimmed back the duct, and it came together nicely. So I won't steal any more of Dr. Gilna's thunder.
And I will say also the duodenum, as you can imagine, was also pretty ecchymotic and beat up. There was no concern for ischemia or anything like that, but I think that was also something that our Dr. Sleeman, the hepatobiliary surgeon, mentioned as part of his decision making.
Yeah, very interesting. Okay, I think you can move on, Dr. Gilna.
Yeah, I think the only other thing to mention for our specific repair, when we did the hepatocogeginostomy, we also did what a Hudson Russell, so we tacked up a proximal segment of jejunum to allow for IR. And if anybody doesn't know what that is, we tack up a distal part of the jejunum, and we'll put staples on our sutures that we tack up to the peritoneum, so that later IR can use those as guide points to then access the jejunum. And so if there's stenosis and there needs to be any dilation, then they can do it that way, because obviously you can't access it with that repair for an ERCP.
Great idea.
So here's just a picture of our repair. Obviously very pretty and perfect. Left drains and closed the abdomen on that that operation, and took him back to the ICU.
Modelo.
That's great.
Maybe later.
So the patient was extubated the next day. He was able to start a diet post-op day 3. All of his labs had normalized on post-op day 3. But then on post-op day 4 and 5, his white blood cell started to go up. His alk phos also was increasing. And then his bilirubin had remained normal as well, though. At this time, his vitals were normal. He was tolerating a diet, but again, was having these changes in labs. So this is, I think, another decision point. So wanted to ask what people would do next.
All right. Any thoughts, Dr. Untracht?
So isolated leukocytosis and alk phos rising, and the other LFTs were normal. So that's a little perplexing. I would, in this case, I would go back and do a CT scan of the abdomen. And I forgot to mention before, so if you had avulsion of the common bile duct, then you also worry about an injury to the head of the pancreas. I assumed you looked carefully for that and ruled it out.
Yeah. Sorry for not mentioning the pancreas had a small hematoma at the head, and we obviously left drains, but otherwise seemed relatively normal. And
at the head where the avulsion was. So
right.
And isolated alk phos, it suggests something like ductal stenosis, but not with the bilirubin coming down. And but I would do a CT scan, look for any undrained collections, and an abscess forming, pneumonia at the basilar segments on the right. Do all of those things. He probably had a urinary catheter, culture the urine, just do all the usual. And I assume he had a fever also. So, fever workup and infection workup. And he's how many days now post-op?
It was post-op day 5 was the
from the first operation. So
from the
yeah,
second one, excuse me. No, from the second one.
So he's far enough out to have all the usual post-op complications. And I don't know what the out cost means, but and I wanted to ask, who did the repair, the biliary repair?
I did along with Dr. Mezoso and Dr. Sleeman, but
yeah, he did a nice job. So I just, yeah, that's you're ready to take over for Dr. Sleeman. So
and he came in on his day off to do it.
Dr. Dr.
Gilna, our resident, came in on his day off to do it.
But you remember when you were a senior resident, you for something like that, you'd come in for that. Come on, that's worth coming in.
I wasn't going to miss it.
How better way can you spend your day off when you're a senior resident? Give me
That's
a break.
right.
Yeah, good. That was a good job.
Excellent. Dr. Kasim, I think you have a question, and also can you comment on the next steps?
I think that was the prettiest repair I've seen by a senior resident. It was beautiful, Dr. Gilna. You're a talented surgeon. The other question I have is, why didn't you do an enteroenterostomy to bypass the hepaticojejunostomy and anastomosis?
I might have Dr. Mezoso answer that because I'm not.
So we discussed it.
Yeah.
We discussed it, and Dr. Sleeman's feeling was that it didn't really add a whole lot to the operation, and we kind of had a little bit of a discussion in the operating room about how maybe that part of doing these reconstructions is maybe of historical interest. But I'd be interested to hear your thoughts.
I think it avoids the food going anywhere near your hepaticojejunostomy. It bypasses it, and it gives you another security feature. I always do that for the fear of causing some problem to my vital anastomosis just under the liver. That's my thought.
Thank you. Yeah.
That's great. Any other thoughts? Any other different things that anyone would do in this case? Dr. Hoffman?
I would do a CT, but and the alkaline phosphatase is rising, so you are worried about an obstruction, probably a structural adenomyosis. But I wanted to just point out that these patients with hepatobiliary anastomosis, they have alkaline phosphatase elevated for life. So that's not an unusual finding. Granted, it appears to have doubled in a few days, so I will be and the white count is coming up, and so I will be worried. But if we were an isolated finding, that's kind of normal, that's expected. So I would do a CT scan on this guy and see what happens. And if that doesn't give me an answer, he will have to have a PTC. They will have to call IR and do a PTC to see if it's any structural anastomosis.
Okay, excellent. Dr. Gilna, you may continue.
So we did the CT scan, as everybody said, and I'll play it here. So you can see that there's some significant biliary dilatation, and then you can also see that there is a small biloma here, kind of in between segments 4 and 5. This is where our our hepatic laceration was. So we, at this point, decided to also get an MRCP to try to better delineate if the biloma was related to the biliary duct dilatation or the laceration. I didn't pull up the images because it pretty much looks identical, and we concluded that it was more related to the liver laceration than it was to the biliary duct dilatation. And so again, kind of as Dr. Hodgman inferred, we had a discussion about getting a PTC, but again, this is kind of the next, what would you do?
All right. Dr. Hoffman?
Well, now you have a intrahepatic collection. You probably put a drain there and see what happens. That can explain. If I have to take a guess, and it's not related, it's related to the liver injury. you have transected bile ducts there, creating the biloma inside the liver, and that will cause elevation of the alkaline phosphatase, because there is an obstruction in those, in the intrahepatic ducts draining into that biloma. Technically, that's an obstruction, and that will increase the alkaline phosphatase. And it will not change your bilirubin. You can get one of the hepatic ducts, and the bilirubin will not change, but alkaline phosphatase will go through the roof. I will put a drain now there and see what happens.
That's great. Dr. Untracht, do you agree?
Yeah, certainly. And then also, you did, what's the eponym for that procedure where you tack the jejunum distally up to access, what's that, the name?
Hudson-Russell is...
Hudson-Russell. Okay. Well, you don't need to do that here. It's easier. You can do it, as Dr. Hochman said, PTC, since the ducts are dilated, and you can see from above, and then you can also leave a drain if you need to. But the bilirubin was normal. So, but if there is an obstruction, you would have access to drain it after the anastomosis, or to dilate the anastomosis after it's healed. And I agree. The biloma should be drained.
Great. Any other thoughts, Dr. Kassim, Dr. Byers?
I don't have any comment. Very nicely managed case.
That's great.
So we obviously discussed putting a PTC or draining the biloma. And while the white blood cell count had been rising, he never had a fever, never had tachycardia. He was tolerating a diet all throughout this time. So from, again, discussing with our senior partner, Dr. Sleeman, he had recommended just for a day or two, we started on urosodiol, and he was saying, as you kind of expect, the dilatation is likely just from swelling. He wasn't concerned that we had a stricture at our anastomosis. I mean, it's something that you need to be concerned about and consider, but we just started urosodiol, saw how he was going to do for a few days, and obviously if the numbers keep getting worse, we'd already talked to IR about it, and they were on board whenever we called them and wanted to do it, but we ended up just not doing anything and watching him, and his numbers started going down. His alk phos dropped to 220 within 3 or 4 days. We removed his drain, and he went home on post-op day 8. And then we saw him in clinic 2 weeks ago, or 2 weeks post-op, excuse me. Again, his labs were all downtrending or normal. And then lastly, I think we're running out of time, but our plan for him, and there's a couple papers on it, but our plan is to follow him every 3 months with labs for the next few years. And then there's some data on patients that get hepatic osteotomies for biliary duct injuries, obviously not traumas, but still, even 20 years out, they can have stenosis, and they recommend pretty much following these patients with at least labs for their lifetime, or 20 years to their lifetime.
All right, excellent. Dr. Untracht, any final comments on the case?
Yeah, superb case. I mean, this covers like, half of Mango's abdominal operations, or what's that series from Hopkins? I mean, you were really lucky, sir, to have had a case like this in your senior year. And superb management. And then, did you leave the gallbladder behind? Did you have to take it out?
Oh, excuse me. We did a cholecystectomy, yes.
Okay, good. Yeah, because then that would be a problem if he gets 19 years old, gets gallstone, right. Got a lot of scarring there. So that was, and of course that's the other option, to use the gallbladder for a reconstruction. That would have been in the old days, the generation before mine, that you would just mobilize the gallbladder, or just ligate the duct and do your anastomosis, your jejunal anastomosis to the gallbladder. often works. But what you did here was superb. So really, one of the best cases I think that we've had presented here in a while, simply because it presents all of so many good classical principles and very well handled.
Yeah, I was going to say the same, because not only the case is fantastic and the management was perfect, but also it was really well documented. So that's it's really enriching for this meeting. Thank you very much, Dr. Gilna, Dr. Mesoso, for this. Dr. Hoffman, any final comments?
I concur with Dr. Untracht. I am very envious that you had this case. And the only thing I would say is better than this case is to be in the place where Dr. Kasim is right now. I would be more envious of that. But otherwise, I wish I would have a case like this. Thank you.
Dr. Kasim, any final comments or a response
Well,
to Dr. Hoffman?
yeah, to lie on the beach in Puerto Vallarta listening to Dr. Gilna present an excellent case is just icing on the cake. Well managed, well documented, everything done so perfectly. Just a beautiful case. Thank you, doctor.
Yeah, Dr. Mesoso, do you want to make any final comments on the case as well?
Yeah, no, thank you everyone for your very insightful comments. This was one of those things where luckily for the patient, it happened in the middle of the day, which doesn't usually happen for these. The next one Dr. Gilna and I had was in the middle of the night with a pretty horrible gunshot wound to the IVC that shredded it. So we had extra hands. I was lucky enough to be able to call one of my other partners who just happened to be around to help us again. I think it was Dr. Kasim who mentioned initially, one of the first things you want to do with these is ask for more hands if you're able to, right? And once we saw that bleeding, I called out for one of my other partners who was covering a separate service that day, who just came and held a sponge stick. And that really makes all the difference in being able to successfully manage these. And then the other thing I'll say is that every single trauma fellow in our program is very jealous of Dr. Gilna for having gotten 2 of these cases in his last month as a chief resident on the trauma service.
We're a good or a bad combo, however you want to look at it, Dr. Mesoso.
That's great. Dr. Gilna, any final comments on the case?
No, thank you everybody for your feedback. I really enjoyed speaking to all of you. Thank you so much.
Yeah, thank you for presenting, and thank you, Dr. Mesoso, as well for being here. Dr. Martos, do you want to make any comments?
Yeah, I want to say thank you very much for everybody for a great presentation, another great meeting, a lot of interaction, a lot of collegiality here in this group. And Dr. Menegoso, thank you very much for organizing this, leading this meeting now on Mondays. Has been amazing, and let's keep moving. So again, this meeting has 15 years of history, and looking for 15 more years on that. Thank you very much.
That's great. It's my pleasure. So everyone, thank you very much for being here today.
Carlos.
Oh yeah, Dr. Gustavo.
Carlos, thank you. Excellent case. Congratulations. Just one suggestion. It's a good case to present to a Congress. Maybe a resident, a medical student can prepare abstracts about this case. And I think for the Pan American Trauma Society, you cannot submit for this year, maybe for the next year. But the team from University of Miami, they can submit to the World Congress of Trauma and Emergency Leagues that will be held in Campinas next July. So to submit abstracts is until April 4th. Okay, so it's a good option to bring the new generation in the trauma surgery and the acute care surgery. Thank you.
Thank you, Dr. Fraga.
That's great. Thank you. So everyone, once again, thank you very much for being here today. I hope to see you all next week on Monday. We're going to have another very interesting presentation. And that's it, Dr. Gilna, Dr. Mesoso, thank you very much for presenting the case. Great case, actually, and hope to see you next Monday. Bye-bye.
Thank you.